Our next speaker is Dr. George Kovacs, who's going to speak with us about new emergency medicine guidelines for the difficult airway. How do you get started? So Dr. Kovacs is a friend and colleague from my shop in Halifax, Canada, where he's a full-time professor of emergency medicine with a cross-appointment to many other departments in our faculty of medicine, including the Department of Anesthesia at Dalhousie University. He works clinically as an emergency physician and a trauma team leader in Halifax, and is medical director of LifeFlight, our provincial critical care transport program. He's medical director of the clinical cadaver program as part of Dalhousie University's human body donation program. He developed and continues to run the very successful Canadian AIM Airway Education program, including courses using human cadavers, and has authored or co-authored numerous articles, textbooks, and airway guidelines. Dr. Kovacs, thank you very much.
Thanks very much for your attention and the invitation. My name is George, and I'm at nowhere, which means that I've gotten off all social media platforms about 2 years ago, and that will not change. This is where I live. I live in Halifax, Nova Scotia, on the east coast of Canada. And as Adam says, I work as an emergency physician and a trauma team leader. This is a cartoonized picture of us doing an RSI during COVID, and a medical director of our critical care transport program. Nova Scotia is a wonderful place to live, and this is my sort of sanctuary. This is a place I built 42 years ago with a handsaw and a chainsaw, and it's a place for decompressing mind, body, and soul. It's also a place where I get to play with toys, and I do have all of my digits so far. I began my talk the other day with this, is that really fear has been a driving force for me in my pathway in terms of emergency medicine, but my pathway also from an airway perspective. And it also is about being here. I'm very much aware of the fact that I'm not an anesthesiologist, and the name of this Congress isn't Anesthesiology and Emergency Medicine, but I was still invited and appreciated it. And the first day in the workshop, I was made to feel very welcome and privileged to be part of this. But fear goes back to me 34 years ago, where I finished my internship on a Wednesday, and on that Monday I was working in a small hospital where our team was myself and 2 nurses, and a train hit a vehicle, and there were 2 patients brought in by our then taxi drivers who get out of their cab, hop in the ambulance. I'm not going to go into the details of how that went, but I just remembered feeling at that point that wasn't a comfortable space for me then or in the future. Ultimately, I went back, I did a residency in emergency medicine, and I came back to Halifax, and Halifax has a rich history of collaboration between anesthesiology and emergency medicine. And there were numerous physicians that were dual trained in anesthesia and emergency medicine. And these people are my friends and have been my mentors over the years. And I've got to hang out with some great airway experts and enthusiasts over the years in emergency medicine. I do need to acknowledge the fact that I do receive protected academic time from the university, and I'm co-director of the AIM program, which is sponsored through the Canadian Association of Emergency Physicians. The most important acknowledgement that I need to make are the people who have donated their bodies as part of Dalhousie's human body donation program. They have been my greatest teachers over time, and they have collectively saved more lives than I ever will as an emergency physician. So airway guidelines for emergency medicine, where are they? Well, it's pretty simple. I could stop here because here they are. There really aren't any that are out there that are labeled as such. And if you look at the history of guidelines over time, and where they were and what guidelines actually involved emergency physicians. The first one was the Canadian Airway Focus Group back in 2013. And then subsequently, the newer ones published in Part 1 and Part 2 in 2021 that myself and another emergency physician was involved with. The SAM publication on consensus of the physiologically difficult airway did have emergency physicians as part of the consensus and writing group. And then you've heard already about the prevention document and that there are 3 emergency physicians as part of that. Now, during COVID, there was no shortage of guidelines, and there are many examples of emergency physicians who were involved in writing those. Adam Law and myself were the lead authors of writing the COVID guidelines for our province that was relevant to anesthesia, emergency medicine, and critical care. I ask you here to look and say, is this an Italian glottis? Is this a French one? Is this a Japanese one? I don't know about you, but I can't tell you. I will tell you now, it's actually my glottis. And like Ross Hoffmeyer, one of my educational passions over the year in teaching has been to look at my own anatomy. And this is not my glottis, obviously, that's my carina. So where I'm going to take you at this point is really taking the Canadian Airway Focus Group guidelines published in 2021, which doesn't use the term anesthesiology or anesthetist. It uses the term provider, and it's meant to be relevant to various disciplines and how this is applied to emergency departments. So when we deliver AIM, Airway Interventions Management and Emergencies across the country, which is taught by anesthesiologists and emergency physicians, we use these guidelines and integrate these guidelines with some mild adjustments. And I'm going to take you through this. So the Part 1 document is difficult tracheal intubation encountered in an unconscious patient. I'm just going to take you to Tuesday night in our emergency department. The 45-year-old took an overdose, and when the pre-hospital crew picked him up, there's evidence of aspiration. They're non-purposeful from a stimulus point of view. They clench their teeth, and these are their vitals. You don't need me to tell you this person is sick, and they're going to end up with some plastic. That's an important principle that we are focused on placing plastic, and this is a quote from Rich Levitin. Patients don't die from acute plastic deficiency syndrome. They die because we're not paying attention to their physiology. We do know that outside of the operating room, bad things happen. The incidence of requiring 2 or more goes at intubation is not uncommon. Severe hypoxia occurs frequently. Severe hypotension, and I remember when the Intube study came out, I texted to Max, I said, you guys made a mistake. You guys were talking about the MAP of 65. He said, no, the systolic blood pressure of under 65. And if you don't resuscitate these patients, 2 to 3% of them will develop cardiac arrest, of which only 50% of them will get ROSC. So the principle is resuscitate before you intubate. And I've been doing this for a very long time, and it's very, very, very rare that I have to run into a crash intubation. The patient's got a GCS of 3. Well, you have GCS of 3, you still have tone. You're not going to be able to rush in and just place the tube. So you've got time, resuscitate your patient. Now, whether it's per-oxygenation or whatever term you're going to use, I use the term peri-intubation oxygenation. And again, these were some photos and videos that were used as part of our training for COVID. We call this super BVM, and every BVM that we have in our department comes outfitted with this. So this is poor man's CPAP, this is poor man's BiPAP. Waveform capnography, you can connect it to your viral filter. You've got a pressure manometer there, and you've got a PEEP valve on, whether you administer PEEP or not. All of that's there from a visual trigger. We all know that now your saturations are 99%, but if I were to give you rocuronium, and I'll give you some propofol also, but how long would it take you to critically desat? Well, it would be very, very quick. It would be about 90 seconds. Saturations tell you nothing about safe apnea. It tells you nothing about oxygen stores. So ultimately, our resuscitation approach is we want to increase the amount of available oxygen, and we want to decrease the oxygen consumption. How do we do this pragmatically at the bedside? I really like this paper. It was published in Lancet, Casey and Semler, and it really gets you to look at the peri-intubation oxygenation and look at it at 3 phases. And while we tend to have a lot of focus on apneic oxygenation, it's great, but the more important part of this is really about what happens before you give any drugs. So the phase 1 is what we all talk about, is pre-oxygenation. Whether you have end-tidal oxygen, in most emergency departments around the world, we don't have access to that, so we're using a surrogate marker, and that surrogate marker is time. That you're going to leave enough time that you're going to be able to wash out nitrogen, and that you're going to be able to increase your stores. And you can do that via various techniques. If you've got normal lungs, you can use a non-rebreather on its own. If they've got abnormal lungs, then we're going to augment that. And whether you augment that with, again, poor man's CPAP or poor man's BiPAP or a non-invasive ventilator or high-flow nasal oxygen, which works well other than the most severely hypoxemic patients, and it's well tolerated, but you're going to do that for an appropriate period of time. Then you push the drugs, and you've got to wait for these drugs to work. And what do? Is we leave the nasal prongs on, and we will ventilate a period. It gives you the reinforcement that you're able to do that. And guess what? It decreases the incidence of hypoxemia. And then what we're going to do is phase 3 is we're going to either leave the nasal prongs on, or what I'll do in the sickest patients, I'll do transdermal, high flow nasal oxygen. In other words, I'll have it on their forehead. And when I take off the mask, I drop it down into in their nose in patients that I think is going to be complex and is potentially going to take more time. So to summarize that, pre-oxygenate with super BVM. Non-invasive ventilation is really the way you have to go. If they've got a high respiratory rate, there's just no way you can time your ventilations, with somebody who's got a respiratory rate of 25 or 30, and you want it to be triggered by their inspiratory efforts. We use waveform capnography here. I've had many situations where they walk in and their SATs are terrible, and they said, we're just going to abandon this and start pushing the drugs. And I said, put on your waveform. They put on the waveform, and they got a shitty seal. They make some adjustments, they've got a good seal, and the saturations come up. So we use waveform to tell us that we need to do a better job in terms of pre-oxygenating our patient. Now, ventilation is gently and slowly, because what do we do when we're adrenalinized? This is a tribute to Ross Hoffmeyer and Max Sorbello. This is a great term. It's a gentilation, and if you looked at the video that was happening during there, it takes about 4 to 5 breaths when there's some PEEP to essentially recruit, and your need to give more than 6 ventilations will be unusual, but let's pretend you were. It was 1. What did you have for dinner last night? No, you. Was it good? 2. That's 10. That would be the rate of doing it at 6 breaths. You can't do that. The point is, don't overventilate that patient. Give them what they need, recruit alveoli. And then phase 3 is don't take the mask off too early. So you've got recruitment here, and look what happens when you let it off. Right? As soon as you take that face mask off, you lose all of that recruitment. So you do that at the last minute, and it's the reason why you want to limit the time in the mouth during that phase. So safe apnea, what do we do? We increase available oxygen. How do we decrease consumption? Well, give them what they need. If they need fluid, give them fluid. If they need blood, give them the blood. If they need a pressor, give them a pressor. I've had situations that walk in, but their blood pressure is 70. You can't sit them up. I said, yes, I can. I can make that blood pressure higher. I'll do whatever the patient needs for that scenario. And then we use a checklist, and there's a lot of debate and argument about checklists. And to me, it's pretty simple. It's about not forgetting the stuff that you are going to forget. It's about the little stuff. And the stuff that's in red here, if you miss those, something bad's potentially going to happen. It takes no time whatsoever, and it's a key thing. You realize you hadn't positioned your patient. Now, I got ... in terms of ketamine, and these are the doses that we'll use. Ketamine at 1 milligram per kilogram, rocuronium at 1.5 milligrams per kilogram. And we can debate about why those doses are used in the ... is because the misused term of DSI that I'll talk about perhaps at the end of it. This is the most common induction or most common RSI combination. So this is the approach that we take us through. We suggest optimized video laryngoscopy, and it could be MAC VL, number 1, plus or minus a bougie, or a hyperangulated video laryngoscope. And as it's been said yesterday, it's not about the device. A device isn't going to come in the room, jump into your hand, and find the airway. It's about you being experienced with that device and being able to use it. So use what you are most comfortable and enabled to do. Now, this is the scenario, though. You go in and you see, geez, that looks like the bougie is in the right place, but you announce, I'm not sure I'm in this scenario, and you don't see sustained waveform in this. Well, you've heard this over and over. What are we going to do? Well, to cut it short, we're going to remove the tube. We're going to attempt ventilation, face mask, or the supraglottic. And again, this is not something that happens to inexperienced people, and some will argue that the more experienced people are more susceptible to this. because they can't believe that this is happening to them. So both of these cases, I've got tons of images here. The tube is not in the right place. What do? Breathe. This is actually where the algorithm begins. It begins after a failed first attempt. So unsuccessful first attempt, what do? We pull out, we do face mask ventilation or supraglottic airway ventilation. And if we've got sustained waveform, remember that the saturations may continue to fall. This is called pulse ox lag. I look up and I look at waveform, and there's somebody in the room, and I promise you they're going 82, 80, 79. And you just have to say, yes, we got good waveform, saturations are going to come up. Then it's limited additional attempts. So if you've done completely everything, you've optimized your first attempt and use a bougie, then what are you going to do next? Well, a hyperangulated blade might be the rescue if you're experienced in it. Or, I've got Karen's coming to visit me, and she just knocked on the door and said, hey, I'm here. Then it's like, boom, you get in here, support me. But the point is, insanity, the definition, according to Einstein and is doing the same thing over and over again, expecting a different result. So you're going to do something different. If that fails, this is when we sort of say you're declaring a failed attempt. You ask the question again, is ventilation, oxygenation okay? At this point, in the ED setting and whatever, we're saying it's tap out time. If there's something you haven't tried, then that's it. And tap out time for us is not canceling the case. It's putting a supraglottic airway in, and then potentially somebody else, if they've got the skill set, they can intubate through them. So breathe. You're okay. Here's the trouble, though. We're moving over to this. At any point during this, you can't face mask ventilate the patient or supraglottically ventilate the patient. Then this is the can't ventilate, can't oxygenate. This is where I define the term psychological shock index. Your psychological shock index is when your heart rate is greater than your patient's heart rate. That often can be a scenario that will actually impede your ability to perform complex tasks, such as performing a cricothyrotomy. So what's happening here? To me, you're going to see waveform that's not so good, and then the saturations begin to fall. So I don't really care about a number. If I've got abnormal waveform and my saturations continue to fall, I'm going to declare a can't ventilate, can't oxygenate scenario, and really you should be moving to do a front of neck airway, cricothyrotomy, neck rescue, whatever the hell you want to call it. You're going through the cricothyroid membrane with some blade and some plastic. Now, before you do that, you might sort of say, listen, if you haven't done your first attempt and you just put them off to sleep, well, you're not going to skip on. If there's something you haven't tried, then you're going to give it a go. And one of the pieces here, a lot of people have trouble wrapping their head around this, is that we're going to make sure that patient is adequately paralyzed. Because everything is easier in a paralyzed patient. Your mask ventilation, your laryngoscopy, and yes, performing cricothyrotomy. I train special forces, and you talk about them with inspiratory effort, with somebody tugging, like this, you're going to find the cricothyroid membrane space. You're not going to be able to do that. Your default is going to be going through. There's a lot of debate about what technique you use. And this is, again, one of our clinical cadavers. What's key is that stabilizing the thyroid cartilage, because there's incredible lateral movement, a vertical landmark incision, through which now you can palpate the cricothyroid membrane. The finger retreats to the bottom of the thyroid cartilage, a stab incision, and it is extended in both directions. There's some people who don't like this, but this is an example of in our cadavers, we pop down a scope, and you can actually see the palpation of them sort of trying to figure out where it is. And then you'll see that's the cricoid cartilage down below that's bouncing, and here comes the blade. Ready? 1, 2, 3, and the blade is in. Extend in one way, turn it, extend in the other way. That's it. It's okay. We're all surrounded by cartilage. Then your finger goes in there, and I will guarantee you will never forget where you are. You feel cartilage all the way around your finger. We put the bougie behind it so we feel it. We feel it slide over the pad of your finger, and then follow with a 6 endotracheal tube. All right, so they're telling me 1 minute in the background. I might take 2, but thank you for that. I'm not going to be talking about the part 2 because of timing, and that was my plan. But this is your decision-making with the anticipated difficult airway. It involves asking numerous questions, but I am going to give you a bit of a poke on this. This is a patient that I ended up doing a flexible scope on. Their tongue was hanging in the mouth. They had sublingual purulence. and then you go in. You've ever seen an omega epiglottis with the epiglottis plastered against the posterior pharyngeal wall, and there's lots of secretions. Again, sort of navigating around there and suctioning it. And ultimately, again, you sort of see things, moving about, and then you see your friend and you pause for a sec as you take a couple breaths, you pop through in a second, and you're starting to see what I call the smooth muscle highway above. This is being done face to face. Go down to carina, hold in position. There's a bunch of secretions there. I always use a Parker tube, follow with the tube. I'm able to sort of see where it is positioned in a second here, and come back, sort of see where it is and come out, and that took 50 seconds. So we train using clinical cadavers, and this is an example of a clinical cadaver, and from an anatomy point of view, we sit them up as we do this, and I was doing this as one of our training videos. And again, if you look at the anatomy here, the anatomy is pretty damn convincing. And so I did this in preparation for some talks. I'd go through the mouth, and then I'd go through the nose, able to sort of travel down. You have to do a jaw thrust in them, in these cadavers, because as they lay back, their structures will follow back sort of posteriorly. You see carina quite clearly, and then you come out, and again, I'm not sure how long that took, but not so long, and then I do another one where I go through the nose. I spent the past 6 years talking about time to wake up and make the awake approach a real option in the ED. I do it very frequently because I do them for the physiologically difficult patient. The patients on BiPAP, and they're apnea intolerant, then that's the person I'm going to do that on. So what is this? You tell me. That's a bunch of adults trying to make their grandkids smile when their son-in-laws are holding the baby. When the moms come along, there's clearly smiles. There's no problem in doing that. Thank you very much for your time.